Cardiology Pearls 2022. When I was invited to do this talk a couple of months ago, they asked me for a topic, so this is what I came up with. I think I've more recently been regretting it because it seems to be rather hard, a very large field to talk about everything, or at least standout areas in cardiology, but that's what I'm trying to do. I'm a cardiologist and electrophysiologist, as most of you probably know, at John Flynn. Cardiology, heart disease has really been sharply brought into focus for most of the Australian population recently by the deaths of Rod Marsh, Shane Warne and Senator Kimberley Kitching, apparently from heart attacks. Yes, well, it's thought to be. In Shane's case, it seems like
very unlikely.
No, it seems very likely it was a typical heart attack to me. Yeah, yeah. He had. Yep. Yep. Well. There's a theory. Why adopt? You know, accept the simplest explanation for something because it's mostly true. That's my take on it anyway. As for Kimberley Kitching, well, apparently the mean girls were being mean to her, and I reckon they might have given her Takotsubo cardiomyopathy, which is stress cardiomyopathy, but who knows? Anyway, it's in the forefront of Australians' minds, so there might be more of them turning up asking for checks.
There already is.
Yeah, there already is. Me too. Now, I'm happy to answer questions at any time as we go along. It doesn't need to be at the end. Up to you. So to go straight to what the nub of the matter, cardiology and men's health, there's a few points I'd like to make. Well, finally, men are getting a go. I hope you're up for it. Men have heart attacks and develop ischemic heart disease in general about 10 years younger than women. Why? Perhaps because of the hormonal changes of menopause are not advantageous to women in terms of developing heart disease. Many men, in my experience and from studies, seem to need help with basic self-care issues and risk factor management, perhaps more than many women, which GPs will play a prime role in. Men, on the other hand, are more likely to have typical angina, which immediately strikes you as being angina, whereas women are more likely to have atypical chest pain due to ischemic heart disease, so you need to have a higher or lower threshold or a higher index of suspicion with women. The other issue, obviously, for cardiology and men's health is erectile dysfunction. And the main point here is that phosphodiesterase inhibitors like Viagra, Cialis, Levitra are totally contraindicated with any form of nitrate therapy such as nitrolingual spray, Imdur, Monodur, oral tablets or nitrate patches because it can cause severe life-threatening hypotension. The other thing would be they shouldn't be used, obviously, where the patient's clinically unstable with angina or heart failure. Final point would be that there is some evidence that the development of erectile dysfunction can correlate with developing cardiovascular disease. Now, that's not infallible because there's a number of reasons why erectile dysfunction can occur, but I've had patients come to me for that reason to have a heart checkup. Does that mean they need to all be rushed off for an immediate angiogram? No, but they do need their blood pressure, cholesterol checked. Are they diabetic? Are they smoking? Do they have a good healthy lifestyle, etc.? And then if they have any symptoms, then perhaps some form of non-invasive testing might be appropriate. So tailored to the individual, but it can be a red flag for the development of heart disease. Broadly speaking, cardiology treatment falls into three categories: lifestyle, such as diet, exercise and smoking; 2, drugs, prescription medication, or in some cases, or many cases, supplements; and thirdly, devices. So I'm actually going to work through in that order, even though for me as a cardiologist, the part I'm most heavily involved in is forms of device treatment or procedures. Secondly, in number 2, but also I frequently do advise in number 1. But that's something that as GPs you can be primarily involved in. The number one point in lifestyle medicine and cardiology is that it appears very simple, that exercise is the elixir of life. From ancient times, people sought the elixir of life, but it was there all along in the form of exercise. It used to be that cardiovascular exercise was the one that was most promoted, so everybody went jogging, going to the gym on treadmills, cycling, and there's no doubt that that's good, but there's more evidence recently that basically any form of physical activity and exercise is beneficial, including strength training, weight bearing, flexibility, balance, things that yoga, Pilates and other things might contribute to. So I think the importance is, so if a patient comes to me and says, well, what form of exercise? The answer is anything. Just do something, especially if it's readily accessible and you like it and you going to keep doing it. Whereas if you take out an expensive gym membership, well, you may or may not keep that up. You don't necessarily need to buy a whole lot of equipment. The other thing which I have a slight interest in is that I think there's a big fad for gyms, but I think outdoor exercise I prefer outdoor exercise. I think it's beneficial, particularly for mental health, to get out in nature, and we're better than O'Reilly's Rainforest Resort. There's a lot of emphasis on pills and a huge amount of money spent on it in development, sales, promotion, and they are important, but the most important one is exercise. Yesterday I did a routine pacemaker check on an 85-year-old man, and as part of the check I said, well, you've got about 9 years left on the battery, and I do this as a matter of information, not as not a prediction, but invariably the ones who are a bit older laugh and say, oh, well, I probably won't need that, or I might not need that. Anyway, he then said, yeah, but I still run 5 kilometres a day in half an hour. And I said, well, I think you are going to need at least that much battery, based purely on that. Moving on.
Do you want questions now or the end?
If you've got them now, ask now.
I still run, and I used to admire a guru called James Fix, who then died running.
Yeah.
And more lately, I noticed that there's less and less indication of any exercise that increases the heart rate for a period of time, such as running. And there's more move towards exercise that keeps the heart rate at a lower level as beneficial for cardiovascular health. Do you have any comments on that?
Yes. So, I think that was on my list of things to say, but I didn't. I overlooked it, so I'm sorry. The only form of exercise that's bad for you is extreme endurance exercise, such as running 42 kilometres, or even maybe half that, or triathlons. Half of the champion triathletes in Australia at one point had severe heart disease, probably related to extreme exercise, and they had defibrillators. So I don't think the body's built to be active, but it's not built for extreme, sustained endurance exercise. As to how much you get your heart rate up, I think some effort's required. Going for a quiet stroll doesn't quite do it. As to how hard you need to push it, well, I think some degree of pushing is beneficial. But as with anything, common sense, anything extreme is probably not good. And the same applies to exercise. Now, this is my favourite slide, apart from Peppa Pig, because I'm a lover of coffee, and I had followed with interest the coffee and health literature over the last 10 years. And to my delight, every study that comes out again and again shows that coffee is good for you. Now, that's not what we learned in medical school or as interns in emergency, where we'd tell people they had to cut down on their coffee for some reason, but that was purely anecdotal. Studies have been done that show that coffee improves mood, memory, physical performance. It reduces the risk of diabetes and dementia, which is a big issue these days. And it probably reduces the risk of cardiovascular death too. How much? Up to 3 or 4 cups a day. Espresso apparently has more of the good stuff, the antioxidants, flavonoids, etc. in it than instant. And the other comment would be, it's not good if you have half the cup of cream and 3 sugars. So obviously, it's the coffee's good, but not if you have too much milk and cream and sugar with it. But apart from that, there appears to be no downside to coffee. Again, common sense applies. So if you have a patient who says, well, after 2 cups I get jittery, well, their body's telling them that's too much for them. But that's purely in terms of symptoms.
Excuse me. Is there any risk of any increased risk of development of atrial fibrillation in
No.
people who drink coffee?
No. Short answer, no. Long answer, no. That's of great interest to me. And it's commonly, the idea that coffee causes AF is purely anecdotal, and it's not supported by studies. Yeah.
I've had cases where I've been in emergency and people have come in,
Yeah.
excessive coffee, developed atrial fibrillation for the first time, and that's anecdotal.
Yeah.
It does make sense to me. I mean, you're going
Yeah.
to increase the heart rate. So.
Yeah, so generally the pharmacological effect is sinus tachycardia rather than atrial fibrillation. So yes, of course, it could happen, but there's probably more to the story. They may have had some underlying propensity to atrial fibrillation anyway, and maybe that acted as a trigger on top of some underlying substrate predisposition. But in large studies, it doesn't cause AF. Now, again, this is swimming against the flow a little bit, but in my view, alcohol is mostly bad for you. It's directly toxic to the heart muscle. Alcohol is toxic to myocardium. It causes, in excess, it causes cardiomyopathy. Some people are more genetically predisposed to that than others. So some people drink gallons of the stuff and never have a problem, and others do. And they can be very difficult cardiomyopathies, although if they're not too far advanced, cessation can result in complete resolution of the problem. Alcohol also causes atrial fibrillation. So I don't buy that coffee does, but I do buy that alcohol does. Now, disclosure, I drink coffee and I don't drink alcohol, so I may be biased. But I think that's what the evidence says. I even have there are even cases of VF cardiac arrest associated with atrial fibrillation going excessively fast related to alcohol or extreme catecholinergic stress hormones. Now, there used to be this story that, well, a few glasses of red a day do you good, they dilate the blood vessels. It might be that there's some beneficial effect in a little bit, with a little bit now and then, but I don't think it's something I'd be recommending personally. And it's notable that the alcohol guidelines from government bodies in both Britain and Australia have gradually cut down from like 2 or 3 drinks a day to 1 a day, particularly in women, and preferably having a couple of alcohol-free days a week. And they've gradually tapered off. So that's the advice I would give. So moving on to category 2, which is drugs. Everybody's familiar with NOACs now, or DOACs, whatever you prefer to call them. But about 10 years ago, I remember giving a talk at Broadbeach on the Gold Coast to a group of GPs when they were in the phase where they were being rolled out on a product promotional basis, where the drug companies, you would enroll a patient and then the drug company would give it to them. That's before it was on the PBS. Since then, and then at that stage, most doctors weren't particularly familiar with them. It now seems to me that everybody is, and maybe they're taken for granted. But from my point of view, they are just such a major advance in medicine from the old problems with warfarin of dosing, diet, and lack of being in the therapeutic range quite often. Basically, there's 3 in Australia, as you know. Xarelto, Eliquis and Pradaxa is the other one. I think Eliquis currently has the biggest market shares relative to the second, Pradaxa a lot less. But in reality, you can use any of them. And if you have a particular problem with one of them, you can try another one. They do need to be dose adjusted for kidney function. So if the eGFR is less than 50, you need to go to the lower dose. I'm very mindful that a renal physician was standing here before me, so that's my nod to renal nephrology. They are easy to take, compliance is easy. There's no evidence that they are more effective and safer with better compliance than warfarin. Warfarin is almost entirely gone, the main exception being for mechanical heart valves, where these are not approved or proven to be effective or safe, and basically having it, if you get a mechanical heart valve, you've got a life sentence of being on warfarin at the present time, unless things change. Dose, how do you choose? Well, Xarelto's, for poorly compliant patients, Xarelto's once a day. Eliquis and Pradaxa are twice a day. So that comes into it. There's soft evidence that Eliquis might cause slightly less bleeding problems. So if that's an issue and the once versus twice a day thing isn't a big issue, then I go with Eliquis. If it's a bloke, this being Men's Health Weekend, who's more likely to take one tablet a day than two, then I'd go with Xarelto. There can be bleeding issues, and mostly they can be managed. Many patients don't have any problems. Many complain about easy bruising. Some people have epistaxis, which can be treated by emergency doctors and ENT surgeons generally pretty successfully. But if they've got a genuine indication for one of these anticoagulants, the benefits significantly outweigh the risks. Other drugs, well, you may have thought that this was ARNI, but in fact this is ARNI, which is an angiotensin receptor neprilysin inhibitor, which there is only one available in Australia, which is Entresto, which is a combination of sacubitril and valsartan. These are much more effective than, say, ACE inhibitors or angiotensin receptor blockers in treating heart failure, but they are more limited by hypertension. So you get them onto it if they can tolerate it. You ramp up the dose to whatever they can tolerate in terms of their blood pressure. In fact, I don't have many on the top dose. It just knocks. I have a few, but mostly it gives them low blood pressure. So I have a lot on the two lower doses. You do have to remember to stop ACE inhibitors for 48 hours before starting Entresto, because otherwise you can get a reaction with very low blood pressure. Not so important with angiotensin receptor blockers, because there is one in Entresto in the form of valsartan. But ACE inhibitors, Entresto, keep them apart. So, NOACs are revolutionary. ARNI's, yes?
Why do you need the valsartan for sacubitril? Do you need
As well.
Do you need the
Well, valsartan, a good question. ARBs and ACE inhibitors both have a beneficial effect on heart failure and left ventricular dysfunction. If you didn't have Entresto and you would choose, ACE inhibitors are still regarded as being slightly better than ARBs, but candesartan has solid evidence for heart failure if they can't tolerate an ACE inhibitor. So valsartan, why valsartan? Because that's just the ARB that they picked. I guess the question is, was the neprilysin inhibitor part of it trialled on its own? I don't know the answer to that offhand. I suspect that many things work better now in combination therapy than single. So I suspect that the combination works better, and they work in different ways. But I'm not all over the exact data on sacubitril on its own, and in case it's not available.
Geoff, is an ARNI something you would expect GPs to be commencing?
Not necessarily, but in some settings, perhaps more rural, regional than metropolitan, it happens. I see patients come in where they have started it. But yes, mostly it's by specialists.
It's mostly there,
Yeah,
isn't it?
yeah.
And I had a lady just lately, 78 years and bad CCF, and she was put on Forxiga, and Arnie
Yeah.
in the one breath.
Yeah. And knocked her
didn't
over?
come in because of COVID.
Yeah.
So I didn't see her, and
Mm.
this was all done in hospital, Ballon Hospital, and discharged, and then back into the hospital 3 days later with a systolic of 67.
Yeah.
You know.
Yeah.
And they stopped it all. And it was so-
Yeah.
Well, she didn't even come and see me
Yeah.
in between. She did a phone consult that was it.
This is an interesting point. I don't know if any of you get emails from Medscape. It's an American-based. They send out CME-based information. I suspect a lot of their funding comes from drug companies, so they produce good material, but it does seem to be biased towards new drugs. And I've watched a few of these recently, and there is a view being taken by leaders in the field that for heart failure, the big four are beta blockers, Entresto, spironolactone, and SGL2 inhibitors, and that anybody with severe left ventricular dysfunction should be on all four of them. And they even say you don't have to gradually titrate them one at a time. So I think whatever happened with that patient, they were probably following that train of thought, which has come from major bodies, but it doesn't sit well with common sense and experience, does it, to hit somebody with 4 new drugs at once?
She's a little bit demented too.
Yeah.
So,
So
still in her own home, but just a bit demented and a bit confused about my pills.
yeah. So my instinct would be you don't start 2 at once. You
just
do good gradually, because regardless of what the big important people in America and Europe say.
So jump back to me.
Yeah.
Go back to your doctor and they can reintroduce them. So how does one reintroduce
One at a time,
them?
slowly.
Just pick
One at a
Doesn't matter
time.
which
It
one.
doesn't matter which
Yeah.
one. Yeah. One at a time, slowly monitor their blood pressure, because you don't want them falling over, breaking a hip, and then going on that downward spiral of broken hip, PE, death.
And
nursing
with
home.
The reintroduction of those, is it a little bit like the sort of bisoprolol thing where you've got to dry them out a bit first? Because do you need to be doing that? I see you have spironolactone in there with all the rest
Yeah.
of the treatments. So
But so spironolactone is there, it's a mild diuretic, but it's a low dose. It's mainly there for its its hormonal effect. It's there mainly for a neuroendocrine effect, not the diuretic effect.
So if they're pretty puffy and fluid overloaded,
Well,
you need to work on that before you start these.
I think it's a good idea. The trend is towards starting those big four at the same time, but cautiously. I think common sense. I think common sense rather than rigidly following guidelines. So if your instinct says, well, let's just clear some fluid, you could maybe start a low-dose ARB or ACE inhibitor, maybe then a low-dose beta blocker, work on the edema, and then once stabilised, then you could perhaps, and the blood pressure's okay, you could switch them from ramipril or candesartan to Entresto cautiously, yeah. So which ones are SGL2 inhibitors? So just in January, dapagliflozin or Forxiga got a streamline number, authority number on the PBS for heart failure, even though it started out as purely a diabetes drug. How does it work? Again, I think the answer is nobody really knows. Probably some metabolic effect. It might have a mild diuretic effect, but diuretic effect on its own probably doesn't cut it. There's got to be more to it, and I think there will be more to that story, but the data is very strong that they are beneficial. Empagliflozin also has strong trial evidence to support it, such as Jardiance or Jardiamet in combination with metformin, but it hasn't gone through the approval process, and they don't have the streamline number yet, but I assume it's going to happen at some point. So at this point, Forxiga, 10 milligrams a day. But I would generally use that fourth line. Why? Mainly because I'm accustomed to starting beta blockers, Entresto, Spiractin first, and then if they've still got problems, I might add, it's only just become available anyway, so I'd add Forxiga then. It can cause, as you probably know, genitourinary side effects, in which case you may have to take them off it. So, summary of drugs: NOACs, ARNIs, SGL2 inhibitors, statins. Now again, statins are controversial. There's a lot of talk, and both in person and on the internet, about how bad statins are for you. They can cause myalgias and dementia. After monitoring this space for a long time, my view is that statins are essential for atherosclerotic cardiovascular disease, or ASCVD. That could include coronary heart disease or peripheral vascular disease or cerebrovascular disease. Why? Because they reduce the risk of plaque progression, they reduce the risk of heart attack and stroke, they make you live longer and probably better. The difficulty is getting which one and getting people to take them, because a lot of people will take one for a few days and then say they've got terrible aches and pains and refuse to take it any further. I persevere, but you have to negotiate a bit. So if they refuse to take one, well, you maybe stop it for a bit, start another one, or start with a lower dose. And in most cases, you can get them on something. In terms of which ones, rosuvastatin and atorvastatin are the so-called high-potency statins, superior to the older ones like simvastatin, pravastatin, fluvastatin. So I would never start those. Do I necessarily change people who are established on them? Sometimes I might, but not necessarily, particularly if they're doing well. But if I was starting, I would generally use, personally, rosuvastatin. And my personal experience, anecdotal, is that it's better tolerated than atorvastatin. The Lipitor people would never accept that, but it's just happened so many times that people, in my experience, that people on Lipitor are more likely to get the aches and pains. There's a thing called the nocebo effect, which is like the opposite of placebo effect. Placebo effect is when you take a sugar pill and feel better because of mind over matter. Nocebo effect is when you take a sugar pill and feel worse because of mind over matter. So it is thought that a lot of the simvastatin statin resistance is due to the nocebo effect. Target is recommended to be generally LDL less than 2 if possible.
So you're not a keen exponent of fenofibrates at all?
No. They have a niche, but well, next slide, hierarchy of cholesterol lowering drugs. So 1, statins, 2, if that's not doing the job, getting you to target in people with vascular disease who continue to have admissions with more stents. Ezetrol, which works differently, it reduces gut absorption. Then you can go to statin plus ezetrol, such as Vytorin or Rosuzet. Fibrates are a niche role, such as fenofibrate, Lipidyl, gemfibrozil. I think it's an indication for diabetic retinopathy with diabetes. It helps lowers triglycerides if there's significant hypertriglyceridemia, and may help raise HDL. But in the general overview is they're much more niche and much milder in their effects. So I don't use them much. The big guns for refractory cases who have very high cholesterol, keep getting stents, and is PCSK9 inhibitors, such as alirocumab or evolocumab, which are the 2 available in Australia. They're injected weekly or twice weekly. They are very hard. They are on the PBS that they're extremely hard to prescribe. It's really cardiologists only, and generally more interventional cardiologists than general cardiologists and electrophysiologists, because they're dealing with the hardcore recurrent coronary artery disease patients. So there's a whole lot of hoops they have to jump through to get it approved, but there is a role for it. So I guess it's there just so you're aware that it exists, and it's the final big gun for refractory severe hypercholesterolemia in patients with ongoing vascular problems. Thirdly, devices. Stents, they work. They work for acute heart attacks, and they work in some cases for chronic angina that is not controlled by medical therapy. They all require dual antiplatelet therapy for 6 to 12 months, generally the interventional cardiologist putting the stent in will advise you on that. Generally, it's aspirin plus clopidogrel or aspirin plus ticagrelor. There used to be prasugrel, which is similar but got removed from the market, I suspect just because they didn't have much of a role in the market. They weren't getting much business. So prasugrel's gone just for the business reasons. Problems can arise when they get an acute surgical problem and they've had a recent stent. That can be difficult and just has to be worked out in individual cases, probably generally by the hospital doctors, the surgeon and the cardiologist, but it can be a problem. There's no easy answer. Pacemakers, they also work. That's an example of a pacemaker with the lead attached. That's the lead that goes through the subclavian vein down to the heart. Pacemakers certainly work for bradycardia. They work for heart failure with cardiomyopathy and left bundle branch block. Leadless pacemakers, I have to say, I'm not an enthusiastic proponent of. There's one there. It looks like a little bullet with a fishhook on the end of it, and that gets stuck into your heart. It can only do single chamber pacing. It can't be a defibrillator. It can't be dual chamber. It can't be biventricular. It can't be removed. It can embolize. So I don't know why anybody implants them, to be honest. I don't. But there is, and I think the name leadless pacemakers is a marketing term. It sounds good. But the reality is when the battery runs out, you can't go in and suck it out of the heart muscle and put another one in, whereas with current models, they're under the skin up here, easy to access. The lead stays in, you just take that out, put a new one in. But they are out there.
Can you cremate the leadless pacemakers?
No, you can't cremate any pacemaker. They can cause an explosion.
But you can't take them out either, so...
That's a very good question. I don't, that's a very good question. I don't know what the answer to that is. I haven't come across it before. I generally find that the funeral parlour people are extremely good at picking up. They'd have to do a post-mortem virtually to take it out. Yeah. I haven't, that's an interesting question. I'll watch that space.
I understand that there's a new, I'm a cremation referee, and lately they're telling me that they can have a pacemaker in with a new sort of oven, basically. But it must only be in certain more modern
right.
ovens. And so it's a new thing that they're telling me that they can in certain places. Obviously, they have to be aware.
Yeah, but it's tricky because they can check if someone's got a pacemaker externally, but they can't tell if someone's got one in the heart. So they're going to have to get it from the medical history, which may or may not be reliable. I don't know, that's potentially a bit of a minefield. I haven't heard of any problems, and I haven't heard the question before. But maybe you have new ovens that's covered. Loop recorders, there's a loop recorder on that display, which is the little slim one. You've probably all had patients with loop recorders. They're easily insertable long-acting Holter monitors, in effect. So they're for the patients who have intermittent syncope, fainting, palpitations, cryptogenic stroke in some cases, where we need a long-acting heart rhythm recording, and they can go in for up to 3 years and they record everything.
So general anaesthetic?
For a loop recorder?
Yeah.
No. They could be done in the rooms under a local. I don't for two reasons. One, I think it would be a bit cruel. So I always give a bit of midazolam and fentanyl in the hospital because it's blunt. You push it in. You cut a little hole and then you push it in. So it's why be cruel if you don't have to? Certainly not general though. Just light sedation, day stay only. Occasionally I'll have a patient who says, well, I want to drive home afterwards, so can you do it under local? And so I occasionally do it, and they survive, but I don't know that it's necessarily particularly pleasant, but it's quick, like a chop to the head, or quick and then it's over.
Geoff, what's
Yeah.
the difference between the ones that go under the armpit and
Yeah.
the ones that go on the front of the chest? Because the ones under the armpit for active men
Yeah.
are quite a hassle.
Yep. So that's subcutaneous ICDs. They've emerged in the last 10 years as an alternative to the standard subclavian ones. but they're much more limited. Standard defibrillator, that's just Dell trying to hijack my computer. Standard defibrillators with leads in the heart are multifunction. They're fully featured bradycardia pacemakers. Every defibrillator is a pacemaker. They also have anti-tachycardia pacing, whereby if the patient goes into VT, it gives a short burst of pacing which can break the circuit and stop the VT without the patient feeling anything. The backup is a shock or defibrillation, which they do feel, and can be, but if it saves their life, well, it's worth it. Subcutaneous ICDs don't have leads. The only one of those three functions they perform is defibrillation. So again, it's like leadless pacemakers. They're a newer development. I'm not a fan, and I don't implant them. I could, but I don't. And it's not really less surgery than putting in a standard one, and they tend to be quite big. The current models are quite big and clunky, and it still requires a subcutaneous lead to go across under the skin up to the sternum, and requires at least 2 incisions. So I just think, well, what's the point? You just put in a standard one with leads, which can be a pacemaker, and you deliver anti-tachycardia pacing as well. I just think it's superior. So yeah, it happens, but I'm not a proponent of it. Right. So summary of cardiology treatment with devices. Stents work, pacemakers work, loop recorders are useful for diagnostic dilemmas, defibrillators for, in simple terms, weak hearts. Ablation, that's my only line on ablation on this talk, and that's what I do. At least that's a lot of what I do. But in the short story, SVT can be cured 98% of cases with a 1-hour ablation. Why would you take drugs all your life for that? But you can. Patients have expressed preferences one way or the other, and it's their choice. They have the option. Atrial fibrillation ablation is, as you would know, done much more frequently. You may or may not know the success rate has dramatically improved from 65% 15 years ago to more like 80-90% now, in most cases. But every patient with AF is different, and some are more established than others. So persistent AF has a lower success rate than intermittent or paroxysmal AF. I personally do cryoablation, which uses nitrous oxide, which is exactly the same stuff as you guys use on skin lesions. It's just piped into the heart through a tube and applied to the trigger points in the left atrium. TAVI. TAVI's a big one. So the advantage is that you can fix aortic stenosis with a couple of days in hospital, quicker recovery, more frail elderly patients can be done than even if they're not fit for open heart surgery. It's rapidly the way valve treatment is going, although it's not yet approved for the youngest, fittest patients for whom surgical replacement is still regarded as the gold standard, but I think that will change. I think this will be the standard treatment for aortic stenosis. Not for aortic regurgitation, because aortic regurgitation tends to involve an enlarged annulus, and it's difficult to completely open out the valve enough to block that off, whereas it works for stenosis. So severe aortic regurgitation still requires surgical valve replacement.
What's the valve that you make?
Or some sort of metal, titanium or something.
Metal?
Yeah. Titanium, I imagine. Yeah. It self-expands. It's positioned, and then it continues to that model, the Medtronic one, continues to self-expand for a few days, which is why you can get late heart block, because as it keeps pressing out, it can compress the AV node. So it's not uncommon for them to need pacemakers after a TAVI.
Any warfarin for life?
No, just antiplatelet agents. Warfarin for life is really only with mechanical heart valves, fortunately. That's the last bastion. Or, in some cases, in people with advanced renal failure, where the renal physicians seem to have retained a preference for warfarin, although my view is that you can use low-dose Eliquis or Xarelto down virtually to end-stage renal failure. But the renal colleagues haven't come on board with that yet. Quick word about a couple of other device treatments in cardiology. MitraClip is the kind of mitral valve equivalent to a point of TAVI, but it's not equivalent to a valve replacement. It is not a valve replacement. It's kind of like putting a Band-Aid on the mitral valve when they're not fit for surgery. The gold standard for severe mitral regurgitation is still valve replacement surgically. If they're not fit for that, they have severe MR, keep going into heart failure, it's possible to percutaneously, again through the groin, up to the heart, transeptal puncture, which is not the approach for TAVI, that's through the artery, but for ASD closure, left atrial appendage occlusion, MitraClip, and AF ablation, the access is by making a puncture through the middle of the septum to get from the right atrium to the left atrium. Now this just illustrates how MitraClip works. So this is the anterior, this is an end-on view of a mitral valve. That's the anterior leaflet, that's the posterior leaflet. You can see there's a big gap in the middle through which the regurgitant flow goes, which shouldn't be there. So basically MitraClip means putting on little stitches to pull it together. Now sometimes they might need to put 3 or 4 in one patient, and they've got transesophageal echo during the case so they can judge how much the leak is improving. So, but if it gets you from grade 4 or severe mitral regurgitation back one level to moderate mitral regurgitation, that can make a big clinical difference for a while. But it can, putting one there doesn't fix that side. But it's useful, but it's more palliative than curative. And of course, as with any of these things, there's always some risk. ASD occluders, that's an Amplatzer device as used to close in atrial septal defects. The indication is if the hole is big enough that there's so much flow across it that it causes chamber enlargement and basically damages the heart in the long run. But that can be done surgically, but as with the trend with so many things, it's from invasive to less invasive, from open cholecystectomy to laparoscopic everything, as you know. So the commonest valid indications are to close an atrial septal defect. PFOs are different. PFOs are a tiny hole which are normal in a third of the population, patent foramen ovale. The foramen ovale is a normal part of the fetal circulation which generally closes down mostly after birth. But in a third of the population, there's still a residual small hole. There are some who believe that that's a cause of migraines and that putting in one of these big things to close a PFO cures migraines. That's still a bit controversial. There are anecdotes that some people find it very beneficial. There are some doctors who advocate it, but it's not generally accepted. And it means you've permanently got that big lump of metal in the middle of your heart. Yeah.
Is it still recommended to use prophylaxis for SVE with any of the people that have these?
Sorry?
Is prophylaxis for SVE still recommended?
Oh, good question. The antibiotic prophylaxis for endocarditis guidelines have stepped back a lot. There's probably not specific guidelines on a lot of these things, including pacemakers. So I often get asked that. So in the absence of official guidelines and evidence, if I'm asked the question, I say yes, 2 grams of amoxicillin. Yeah. But they don't need that for, your typical aortic stenosis or mitral regurgitation, unless there's a device in there. I mean, I think the principle, in the absence of good evidence and guidelines, which there mostly is not there for a lot of these devices, I think common sense would say that if you're not sure, getting an infected device, any infected device in the body, whether it's a knee replacement, hip replacement, or pacemaker, can be really disastrous. So one dose of antibiotics is probably better. That's my opinion, nothing more, but there's nothing else to go on at this point in most of these cases. The final device treatment I want to mention is left atrial appendage occlusion. Has anybody come across this or had a patient have it done? No. So in the left atrium there is a little pocket here. Sorry. Here, which is where clots most commonly form from where they embolize and can cause an embolic stroke and atrial fibrillation. So the treatment for this is generally anticoagulation. This is a local treatment for people, a small minority of people who totally cannot tolerate anticoagulation for any reason. And then this is a transseptal procedure where a little device is put into the left atrial appendage and it clots off, blocks it off, and there's no pocket there where clots can form. I've referred, I don't do the procedure. I could, but I've chosen not to because I don't think I would have a high enough volume to warrant keeping doing it. I refer to, for this, I've referred 2 patients for this to a guy in Brisbane who does a lot of them. And those patients have gone off all anticoagulates and they're pretty happy about it. Is it for everybody? I don't think so, because anticoagulant, firstly it's very invasive, expensive, and all of that has a downside. And secondly, because it's not systemic. That's not the only place where clots can form. So if they can tolerate Xarelto or Eliquis, in my view, that's preferable to one of these unless they can't tolerate the drugs. So this is a summary of my cardiology pearls for 2022. 1, exercise in any form is the elixir of life. 2, coffee is good for you, and I think morning tea is coming up. 3, heart failure treatment has advanced with Entresto, dapagliflozin, biventricular pacing in selected cases, improves heart function, beta blockers for all if they can tolerate it, which not everyone can, of course. NOACs are game-changing, in my view. Statins are essential despite the bad press. TAVI is becoming the standard of care for aortic stenosis. MitraClips can be a useful, essentially palliative treatment for patients with severe symptomatic mitral regurgitation who are not fit for surgical valve replacement. Loop recorders are useful for diagnosing the cause of unexplained syncope, some cases palpitations, which can't be pinned down any other way. And ablation is effective for many arrhythmias. And I think, oh right, so despite all that, there's a few pearls I haven't covered because I haven't had time, such as telehealth in cardiology, supplements, diet, stress and heart disease, home monitoring in various forms, wearable technology such as smartwatches and Fitbits, women's cardiology, although I've touched on it a bit early on, and imaging, echo, stress echo versus CT coronary angiography and calcium scoring.
Can you touch on that one, please?
Yes. And then we're back to Boris and Peppa Pig. The CT versus stress echo. Yeah. So that's a big thing. So a certain time ago, if someone had chest pain, you'd send them for a stress test. Then it became stress echo, adding ultrasound, which improved the accuracy, made it a bit more expensive, but it was a better test. And that was very widely used until relatively recently the government, Medicare, whoever, clamped down on it because they thought it was being overused, which it probably was. and CT, coronary angiography, and calcium scoring has become more widely used. That's my practice. The thing is that they give different information. So in some cases, I'll do both, or in most cases, I'll choose which I think is most suitable for that patient at that point. How do I make that choice? Well, a CT gives you structural information, not functional information. So it gives you a picture of whether there's any significant stenosis. It's less accurate than in-hospital coronary angiography, which is the gold standard, but it's getting better and it's pretty useful. So if you get somebody with chest pain, some risk factors, it's a good test to do, because if it's clear, you can reassure the patient and you don't have to worry as much about it. The role of calcium scoring is well established as well, in my view. It's useful. And if I refer for that, I always ask for CT coronary angiogram and calcium scoring. The role of calcium scoring is that it's just basically an index, or reflects the volume of plaque in the arteries. So the higher the calcium score, the more plaque they've got. And there is a correlation with prognosis from that. Stress echo, on the other hand, it doesn't show you the arteries. It shows you the functional effects of a blocked artery, which is part of the wall, changes on the ECG, and part of the heart not pumping as well. But it's also useful because it's a functional test. So for people who have exercise-induced symptoms, it's often useful to exercise them under medical supervision, so that their rhythm, blood pressure can be monitored. You get information about the heart muscle, heart valves, and an overall interpretation, because they're always supervised and reported by a cardiologist who specialises in that. So different tests. The limitation of CT angiography is the accuracy is a bit less than an in-hospital angiogram, and it doesn't give you functional information, but it picks up cases whereby, say there's somebody with a lot of, say, 10 to 20% stenosis throughout the heart. They've got a high burden of plaque, and they're at a much higher risk of having a ruptured plaque and a heart attack than somebody who doesn't have that. But that won't show up on a stress echo, because it doesn't cause enough obstruction of blood flow to be detected by the stress echo. So if you have somebody, so from my point of view, the utility of a CT angiogram in that case is that I can say, well, you've got a definite case. If you've got a certain volume of plaque and calcium score, you've got a case for taking aspirin and a statin, as well as lifestyle modification. Whereas without that, they could go for a stress test or a stress echo, come back normal, and they just keep building up plaque till they do have a heart attack. So that's where I find it useful. It tells you the people who have plaque, but it's not bad enough to show up on a stress echo, whereas the stress echo gives you exercise-based information.
But if they have a calcium score that's high, they have to have a CT coronary, obviously, at least.
Coronary angiogram.
Yeah.
The thing is that people sometimes pay for just the calcium score, which is very quick. They just go into the scan and bang, it's like an X-ray. And it's cheap and they can pay for it themselves. Whereas CT angiography, again, the government in its wisdom restricts it to cardiologists mainly, at least. So if I tick the right boxes, the patient can be bulk billed for it, whereas I don't think you can. So, no. Again, it's cost saving. Generally, I do them both in tandem.
So if somebody, my usual situation is somebody with high cholesterol, don't want to take statins.
Yeah.
They want to have a CT.
Yeah.
If it's zero, they don't need
Yeah.
Yeah.
You got to look at the whole picture, but yes.
Makes them feel better.
Well, it makes them feel better. I find it useful where they would otherwise refuse to take the statin and aspirin. But once they know they've got some atheroma there, they're more likely to take it, and it's actually likely to be beneficial for them. Because most heart attacks are due to ruptured mild plaques, not severe plaques. Severe plaques cause obstruction to flow and angina, but they're not necessarily the ones that rupture and cause a heart attack. That's the importance of fixing up mild plaque.
And you put them on aspirin as well.
Yeah. But that's not primary prevention then, that's secondary prevention. Aspirin is not recommended for primary prevention anymore except in very limited circumstances. Yeah, 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 yep.
But if they've got a coronary calcium score above...
Certain level. Yeah, the guidelines are always attached to the report. I don't carry them in my head, I look at the report. But it's evidence-based, guideline-based as to what level lifestyle advice is recommended, what level aspirin and statin. But they're the things, so they're not going to benefit the patient symptomatically, but they're going to benefit them prognostically.
So does the statin stabilise mild plaque?
Yes. I believe so, yes.
Because what we want to do obviously is focus on mild plaque rupture.
Yeah.
In reality, but nobody's got any guidelines for that. That's the most critical thing.
It's been very extensively studied. I'm not sure why that is. No, I believe that's what aspirin and statins do. They stabilise plaque, retard progression, and make them less likely to rupture. And if they do rupture, the aspirin makes it less likely that it'll go on to be a full-blown heart attack.
But statins are stabilising as well as diminishing
progression. They don't necessarily cause regression of plaque, which is what people want. They say, why can't you just go in and scrape my arteries out? And the answer I give is that because plaque is it's not like just a bit of gunk attached to the inside of a pipe. And if you go in with a brush, you can scrape it off. It infiltrates the wall. That's why you can't scrape it off. The fat becomes part of the intima and media. But the best way to stabilise it is statins.
Is there other ways or any other new research or ideas that
I don't think so.
Shane Warne in the future?
There'll be a lot of money thrown at it now.
Sorry?
There'll be a lot of money thrown at it now after Shane Warne and Berkeleys and Senator.
Rod Marsh, yeah.
Yeah,
Or maybe Merv's next, I don't know.
It seems to be
I didn't mean to put a curse on him.
It just seems to be a shame. I mean, we know what causes the heart deaths.
Yeah.
And nobody's putting any interest in it.
Oh, no, there's a huge amount of study of plaque and cholesterol, huge.
But there's no like information about how to stop acute plaque rupture.
Yeah, aspirin and statins.
So aspirin's good as preventative primarily as well, perhaps.
In that case, yes. Yes. And aspirin, as you know, knocks out platelets for up to 10 days. So for the patients who come in and say, well, look at my bruises, I can't take it every day. Well, taking it 3 times a week or a lower dose or less frequently still has benefit.
Thank you.
Thank you.